Well, good afternoon, everyone, and thanks for joining us on BritSpine. And before I introduce our next speaker, just encourage you to go to the networking lounge and support our industry partners who have enabled this novel conference. So without further ado, can I introduce my erstwhile colleague, Professor Upinder Sahota, who has transformed orthogeriatric care at Nottingham and has been very supportive in quality improvements in spinal care in our older patients. He has a long list of national and international positions, but latterly as the chair of the vertebral fracture, fragility fracture group of the Vertebral Fracture Global Network, he's been developing transformational guidelines, which he will no doubt signpost you to. So without further ado, can I pass you over to Upinder, who's going to give us some thoughts on how we treat these vertebral fractures. Thank you.
I'd like to thank the BritSpine for the invitation, and thank you to Mr. Mike Grevitt for the kind introduction. Management of acute vertebral and sacral fractures in older people, the role of the spinal surgeon. My disclaimers and disclosure slide. Vertebral fragility fractures are extremely common. They cause significant problems to patients, namely back pain, spinal deformity, affecting lung capacity, impaired function, loss of appetite, increased risk of further fractures, but also increased risk of mortality. These patients present to hospital. Most acute vertebral fractures can be managed within primary care. However, a significant proportion will present acutely to hospital. As we can see from the slide, for both men and women, there's an exponential rise, essentially over the age of 70 to 75, and obviously greater for females. And this is looking at vertebral fractures from our own unit, so in Nottingham, where we're serving a population of approximately 700,000, we're seeing roughly 250 to 300 fractures per year. And if we look at the types of patients who actually present to clinical care, these patients are older, their mean age 79.7 years, they have significant cognitive impairment, they are frail patients, their mean length of stay in hospital is 16 days, and they present with acute pain symptoms, so the mean pain score on admission 8.9 out of 10. What is interesting, that even though we discharge patients, they are still in quite significant pain, mean pain score 5.1, and still in pain at the 6-month time interval. And this also correlates in terms of function. If we look at their pre-admission function, in terms of the Barthel out of 20, that even at 6 months further down the line, only achieving a score of 15.8 out of 20. So significant impairment despite essentially conservative treatment. So how do we manage these patients? Well, clearly optimizing analgesia is really important. Prescribing analgesia as and when required does not really help these patients. And my own preference tend to provide, usually using a patch, either a fentanyl or a buprenorphine patch, which I find extremely helpful. However, we need to move away from what is currently routine standard care within the UK. And UK standard care is to put a patient in bed, fill them with morphine, and if the pain continues, keep adding on the morphine. And then we advocate these thoracolumbar braces, which have shown to be ineffective, but also more importantly, where you have patients who are predominantly quite elderly with cognitive impairment, they find it extremely difficult to manage wearing a brace. We have NICE giving us the guidelines, and now these guidelines are a few years old, back in 2013. And NICE recommends the role of percutaneous vertebroplasty and percutaneous balloon kyphoplasty for treating these acute vertebral fractures. There was some concern and recently published from the Cochrane review showing that or suggesting that vertebroplasty does not work. And certainly this has had a significant impact in a number of countries across the world. But it's really important to look at the Cochrane review in detail and recognize their significant limitations. And these limitations were recently published in the BMJ, when I really would like to highlight a number of issues, particularly with the vertebroplasty trials, which the Cochrane review have included, but actually to be recognized within the limitations of clinical practice. The first I want to highlight is the number of inpatients. So if we look at predominantly inpatients presenting to clinical care, the three larger trials had either 0 patients or were not reported. And only in the VAPOR trial, it reports just under 60% of patients were inpatients. Secondly, if we look at the volume of the cement injected, again in the 2 earlier trials, extremely small volumes, 2.6, 2.8, to more favorably the VAPOR trial, looking at 7.5 cc's. But thirdly, and perhaps the most important, which is overlooked in all of these trials, is the age of these patients. As we've seen from the data that we've actually published, the mean age of these patients who present to hospital are roughly about 82, 83 years of age. And again, if you look at each of these trials, we see 73.4, 74, 74, and really again the VAPOR trial. And what's really interesting, that the VAPOR trial closely mimics the type of patients that we see presenting to acute clinical care, and this is the only trial that has shown a successful intervention in this patient subgroup. More recently, the Academy of Medical Royal Colleges has re-reviewed all of the evidence, and these recommendations were published in November last year, and this evidence guidance will be used to support NHS England, Public Health England, and the NICE update in terms of where we should consider vertebroplasty intervention. And what this says in summary, that vertebroplasty or kyphoplasty should be offered as a treatment for painful osteoporotic fractures on a case-by-case assessment. But clearly in cases where patients have ongoing pain, despite optimal pain treatment, but of noted here, particularly for hospitalized older patients, are slightly different from the NICE guidance in terms of the update. And clearly where the pain has been proven on imaging and correlates with clinical examination, the treatment should be managed and assessed within an MDT setting with access to spinal surgery and governance measures actually taking place. But it's also really important, and actually highlighted within the bottom here, that secondary prevention to prevent the next fracture is also critical for managing these patients longer term. I want to really present a couple of cases to you just to highlight perhaps what is currently current practice and how I feel current practice should really change to try and optimize the care of these patients. This was a patient who presented to us on the acute take, an 82-year-old female, normally quite fit and well active, developed acute back pain while she's in the garden, just pottering around, presented to ED, being log rolled, and the x-rays confirmed an L4 fracture. And from the history, this would suggest an acute fracture. She was transferred across into the medical ward, and at that time, consultant review plan was for analgesia, physio, and left to be. And this tends to be the most common management and how we manage most of our patients across the UK. Fortunately, she was presented to our unit and she underwent an MRI of the spine, and as we can see quite nicely just on the stern, I hope this projects reasonably well, you can see the vertebral edema within the L4 vertebrae. Again, we're quite fortunate in Nottingham that we developed our spine services that, as well as having the regular MDTs every morning, we have elderly care consultant presence for 4 PAs across the ward per week. And secondly, we have a spinal osteoporosis specialist nurse. And we've recently been undertaking vertebral augmentation, and we've looked at the very elderly within our group, and their data is comparable, if not better, compared with some of the younger patients in terms of pain and functional outcome. So this is our patient here, Mrs. OG, and she's currently on quite high dose of analgesia, regular morphine, and just really want to highlight this is a lady who's normally out gardening, fit, active, and really quite independent, and just really struggling to weight bear and requiring the assistance of two. This is a day one, post-operatively having had a vertebral simple augmentation. And this is her now at day 5, ready to go home. Now currently on just very simple analgesia. The morphine has actually been stopped. So huge difference in terms of where we are in terms of managing these patients. And our average length of stay is currently for conservative care roughly about 16 to 18 days. And she was in hospital for just 7 days. There's been a lot of discussion around augmentation and the risk of increased subsequent adjacent level fractures. And essentially, a review of the literature has shown that the risk of adjacent level fractures is dependent on 2 main factors. And those main factors are the degree of kyphosis and the severity of the osteoporosis. So clearly, what is really important is secondary prevention for these patients. And certainly all of our patients within Nottingham that undergo augmentation, we tend to have a low threshold for anabolic treatment for these patients. We tend to bring them up to the osteoporosis clinic for further assessment. There's also some work that's been published, and again, some of our practice tends to favor this there, where you are particularly augmenting around the thoracolumbar junction, there may be an increase practice in trying to also prophylactically cement the vertebrae on either side to try and protect that junction as well. The other group of patients who I feel perhaps get the worst deal in the hospital, those presenting with acute pelvic fracture injuries. Unfortunately, nobody really wants to look after them. They filter around the hospital. And essentially, these are patients who can have multiple problems and can run into severe complications. Data from Nottingham, where we've looked over patients presenting to our acute unit over a 10-month period, which is part of an ongoing NIHR-funded trial, the prevalence of these patients showed that the mean age, again, a little bit older than the acute vertebral fracture patients and also older than the usual hip fracture patients that we see, mean age 86.2 years. A significant proportion have a degree of cognitive impairment, previous multiple fractures, on lots of medication, and again, their length of stay in hospital, mean length of stay around 16 days. The majority of these are admitted to the elderly care departments or general medical departments across most hospitals. But what's interesting, when they undergo further imaging, of those patients confirmed on plain film with a pubic rami fracture, obviously 94% had a confirmed fracture following MR or CT imaging, but 62% had a concurrent sacral insufficiency fracture. And I think we unrecognize that. From a spinal point of view, this is well recognized, but from a general medical point of view, it's a very unrecognized patient subgroup. Of those, 13% had an associated pubic rami and acetabular fracture, and 8% had a complex pelvic fracture. So how should we change how we manage these patients and really try and improve clinical care? So again, this is another case presentation of one of our patients who presented acutely to hospital. Mrs. SF is a retired physio, normally active, still driving a car. Unfortunately, tripped indoors and presented with acute pain in her groin, was confirmed to have a pubic rami fracture on plain film and transferred across onto the medical ward for physio and analgesia. But she struggled to mobilize. She could not get out of bed. She's hoisted into a chair and was unable to try and stand up from her chair. This is one of my colleagues just demonstrating. This is the patient on morphine, on regular analgesia, and just trying to get her to stand from her chair. So she presented predominantly with caudal pubic radiating pain. On the coronal section, we could see edema around the sacral iliac joint, consistent with an acute sacral fracture, and she underwent a simple sacral augmentation. And what's really nice to see, this is now her 2 hours after the operations, had her surgery in the afternoon, went to see her about 5-6 o'clock in the evening. So just really extremely rewarding from both a patient perspective, a clinician perspective, and again from a healthcare resource point of view. So in summary, really we need to change how we're managing these acute fractures. We need to think about and recognize acute vertebral and sacral fractures. We need to optimize early optimal assessment of these patients. Analgesia and appropriate tests is really important. My preference is more for topical patch types of analgesia rather than a PRN. At the same time, it's important to make sure that these patients receive appropriate laxatives, because again, with these morphine-based compounds, they can become quite constipated. We need to think about early imaging for these patients. Clearly, X-ray has limitation within the pelvic injuries, and whether we start moving towards more CT or MR imaging for these acute pelvic injuries as first-line assessment of these patients. Most importantly, we need early surgical spinal involvement where there are clearly surgical targets. So we essentially really need your help. And this really can change the care and outcome of the patients. And then lastly, secondary prevention is critical. These patients are high risk of future fracture, so we need to optimize further secondary interventions to prevent their next fracture. I'd like to thank you ever so much for your attention, and we're happy to take any questions. Thank you very much.
Thank you very much for that. It looks like Margaret's mic's still muted. Mike, do you want to unmute your mic? If not, I'm able to welcome Pinder. Thank you very much. We've had a couple of questions in. One of them is, thank you, Mr. Sota. What would you recommend as the optimal timing for vertebroplasty following acute VCF?
Yes, I think, yeah. So that's a really good question, and I think it's often sort of really the timings in terms of what access of services that you have. And I think if we turn it the other way around, the bigger issue is that every day a patient is lying in bed is actually a bad day. So it's really how much or how long are you prepared to allow your patient to be sitting in a bed doing nothing. We know that you start to lose your muscle mass really quite quickly, sort of peaking around sort of day 4, day 5. So it's really what you are trying to achieve. So certainly my rule of thumb is that we tend to optimize really optimal analgesia very early on and really assess the patient at sort of 36 to 48 hours. And if my patients are really still struggling to get out of bed, and they obviously have a clear surgical target, then I think we really need to start thinking about trying to intervene early on with these patients.
So, Binder, can I just, there's a question. Do you have a handle on how many vertebral augmentations you do in a given year at Nottingham?
Yeah, so we've looked at the data, and I'm sad to say that I personally feel that we're not doing enough. If we look at our current practice, we're probably only operating on about 15% of those who come acutely into hospital. And I think we need to increase the awareness. I think we need to increase awareness amongst the physicians to start with, because many of my colleagues are not aware of the intervention or that something can be done. And secondly, we need to raise the awareness amongst our surgical colleagues as well, and to really try and improve that collaborative working. And I'm hopeful that we can have patients can have access to further treatment earlier and sooner. So I think hopefully the tide may be changing with the awareness, and the numbers should be able to go up.
Yeah, and just a subsidiary question: if perhaps we're not doing enough, what is the time threshold, do you think, that we can reasonably intervene?
Well, again, I think it comes back to my earlier point, is that how long do we want to leave patients lying in a bed? We know that their rehab becomes more challenging, the more muscle mass they start to lose. So a little bit like the hip fracture patients, going back many years ago, we thought it was good practice to leave patients in bed, put them last on the list, and operate on them sometime within the week, possibly a week later. And what we've realized now, that certainly targeting surgical intervention within 40 hours is really timely. And so my rule of thumb is that if we have patients who are really struggling to get out of bed, have a clear surgical target, then really, if we can, within 48 to 72 hours should really be the optimum. And that's the aspiration. If we look at the Vapor trial, their patients, their length of stay, they managed to reduce length of stay between 5 to 7 days. So essentially, if you've got the mean length of stay around 16 days, and if you have an intervention where you can trim 4 or 5 days off, then clearly the health economics will really work out themselves.
A technical question, but one that is really important is regards the sort of type 4, grade 4 fractures, where you get perhaps biconcave fractures with fractures of the vertebral end plate. A lot of people are worried about cement extravasation in those instances. Do those patients do as well as the other lesser types of fractures?
Yeah, so all of our patients are discussed within the spinal MDT, and I feel my role is to really try and facilitate the pathway of that patient. And at the end of the day, we will be advised by our surgeons themselves, individuals like yourself, Mike. So where we feel there may be surgical contraindications, and obviously we would avoid operating on those patients. So certainly we're not taking a maverick approach where we say put cement in everybody, clearly where there may not be any help. But at the same time, we will be advised by experts like yourself. And certainly from the experience that we've had, the risk of extravasation is extremely small, because I think we make that assessment within an MDT assessment.
Yeah. And just a question about sacral insufficiency fractures, Pinder. Firstly, if we do see pubic rami fractures, should we of necessity be getting a whole spine MRI scan? And are there any other aspects of the care pathway that we can reasonably put in place to avoid missing these types of patients and injuries?
Yeah. So, I think that's a really interesting point, Mike. And, how do we change practice? I mean, sure, it'd be great to have MRs on all these patients, but I think we have to be mindful of the access to MRI and, the limitations that we have. And I think as a compromise, I feel that clearly patients who are admitted to hospital and clearly patients who are actually struggling to mobilize with ongoing, particularly caudal groin pain, we should have a low threshold for further imaging. Because clearly if we have a surgical target, then we can offer something towards these patients. What is also really exciting is the role of dual CT. So dual CT is coming forward, which allows you to look at the bone edema as well as the bone morphometry. And that may replace, particularly for the pelvic fragility fractures, first-line imaging, which I think access may be slightly easier. So yes, we would like more imaging, but I think we have to be mindful of the challenges that we have within the NHS.
Yeah. And a question about the associated pubic rami fractures. When we do the sacroplasty, should we be inviting our orthopedic colleagues to at least opine on the pubic rami fractures? Do they benefit from open reduction and fixation, etc., in this group of patients?
Yeah, so my understanding and my teaching from my spinal colleagues that I work with is that the predominant load bearing is actually within the sacrum. So 70 to 80% of your load bearing is within your sacrum. And particularly for patients who are sat or having to transfer onto the commode, and when this stand, that's where you get the greatest load weight bearing. So by fixing that, we've been able to get away with, if that makes sense, with just the one operation, because as you will know, that clearly then to try and fix a pubic rami, you need to then turn the patients over and then do another operation. So from our experience, just fixing our experience with just the sacroplasty and leaving the pubic rami has allowed patients to sit, stand up and mobilize reasonably well. So our practice has been just to fix the sacrum, but to leave the pubic rami.
Yeah. And a question really of who should be doing it. Now, we're fortunate in Nottingham that we have a very diverse array of colleagues who can do it, both spine surgeon, interventional radiologist. But in terms of the sort of national direction of travel in terms of provision, where's that going, Upinder?
Yeah, so I think, access is going to be a real challenge. If we're going to change practice, we need obviously more people. We need more interventionists. I think what is really the most important is A, to identify these patients, B, to have a forum where they can be discussed within an MDT forum, to include your, obviously, individuals like myself, spinal surgeons and the interventional radiologists. There may be some cases that are best dealt with the interventional radiologists and some cases that are best dealt with the spinal surgeons. The attractiveness of the interventional radiologist is that patients don't need to really have a GA, and it doesn't put the pressure and access onto the theatres, which is often a real challenge. And again, there'll be many regional spinal services that have more complex surgeries to deal with. So I think it really has to be an MDT discussion, and we need more individuals, and that should be guided from the MDT.
Sorry, gentlemen. Last question, please.
Yeah, just finally, a opinion about complications, because one of the metrics was actually measuring the sort of complications there. What in this sort of very frail group has been things like the leakage? Have we had a lot of pulmonary complications from things like that?
So the answer is no. So I've been looking after these patients for the last 4 years now, and I have to say that we have very minimal complications. You do get some cement leakage, but we've not had any major problems. And I think we have to recognise also in the context of non-surgical interventions that the risk of complications of patients lying in bed, the risks of DVT and PE, is also extremely high. So I think taking it into those contexts, I think it really has to look at both ends. But our experience has found that in safe hands, and obviously going through the MDT, that the procedure is reasonably safe.
Thank you, Upinder, and thank you for everyone for contributing, and thank you, Upinder, for challenging some orthodoxy that's out there and giving us some food for thought. And on that, I'll close the session. Can I remind anyone If you have any further questions, please go into the networking lounge or send Professor Sahota your questions. But on that note, I think it's time to close. And I hope that you will remain and enjoy BritSpine. Thanks very much.
Thank you.
Thank you.